Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
VITALS is a national open forum to hear from the nation's leaders who are transforming healthcare using the VITALS tools: value, innovation, technology, leadership, and service. Today, we are very pleased to bring you our speaker, Dr. Ted Teknos. Dr. Teknos is the president and director of science at the Seidemann Cancer Hospital, part of the University Hospitals Cleveland Medical Center. Dr. Teknos is also the deputy director of the Case Western Reserve Comprehensive Cancer Institute and is a leader in healthcare innovation and transformation in the oncologic space. He is also the Jane and Lee Seidemann Cancer Chair in Cancer Innovation. Dr. Teknos is a recognized leader in cancer care nationally and internationally. He came to us in the Cleveland area in about 2017. Prior to that, he was at the Ohio State University Wexner Medical Center and also at the University of Michigan Health System. Dr. Teknos is a leading clinician still actively caring for patients, a leading researcher whose groundbreaking work is transforming cancer care, and he is also a well-published researcher with over 200 peer-reviewed research articles. Please join me in welcoming Dr. Ted Teknos to the stage.
Thank you, everyone, for attending, and thank you, Dr. Langell, for that wonderful introduction. It really is a pleasure to be here. I haven't been on the campus here before. It's a beautiful campus, and certainly I'm very impressed with all the work that is being done and the growth in Neomed. So what I'd like to talk with you about today is really the current state of the economics of cancer care and kind of where the future of cancer care is going. So some of what I may say may spark a little bit of discussion, maybe a little bit of controversy, but certainly I hope it is a good discussion for all of us and we can learn together. I have nothing to disclose with regards to this talk. So currently, cancer is what we call a fee-for-service, is paid for on a fee-for-service basis. So what that means is, I joke here, you know, you see this little doctor's office and it's like when you drive by McDonald's, so many served. It's like you go in, you have a procedure, and then the insurance company will pay you for that procedure on a sort of per-click basis. You know, as I'll discuss, that's starting to change a little bit and it's starting to become more value-based, but currently right now it's still being paid per visit and not being paid for continuity of care. Cancer care has become increasingly more outpatient. So when I ask the question, how much cancer care is outpatient, currently 2/3 of it is now outpatient and only 1/3 of it is inpatient. So it's always curious to me how hospitals, including my own, keep building new hospitals, but the inpatient part of care is really decreasing substantially and more care is going to the outpatient setting. Cancer is a huge proportion of what hospitals need really to survive. About half of all margins for the hospital come from cancer-related services, and about 1/3 of all the revenue that comes into a hospital really is due to cancer care that's delivered there. So it's very, very important to the well-being of a healthcare system. Currently, in the state of Ohio, and certainly at my institution, about 65% of the patients we see have government insurance, whether that be Medicare or Medicaid. And then increasingly more have Medicare Advantage, which is kind of the privatized version of Medicare. And then finally, for those of you who are thinking about different specialties in medicine, the primary specialties in cancer are really medical oncology, surgical oncology, and radiation oncology. So I always put this question out, which of those do we think actually contributes the most? Per doctor, and as you'll see here, the radiation oncologist brings in the most money, if you will, to a healthcare system. About $4 million per doctor comes in because of a radiation oncologist. But in aggregate, the medical oncologists bring in much, much more because of that drug cost, the chemotherapy that's delivered, which is really a gigantic portion of the revenue that comes in. To give you an example, our healthcare system, University Hospitals, is a $6.5 billion per year revenue healthcare system. $1 billion of that is in drugs and pharmaceuticals. So, and the lion's share of that is really cancer-related drugs and pharmaceuticals. So, medical oncologists, because of that service, really bring in the most revenue to a hospital. Now, I'm going to talk a little bit about healthcare costs in general. So you can see here that our national health expenditures as a percentage of GDP has just gone up dramatically between 1960 and 2025. It peaked during COVID, where it went above 20%. But you can see it started in the 1960s, about 5% of our gross domestic product, and it's now approximately 20% of our gross domestic product is related to healthcare costs. And when you think about this, it's going to continue to grow. So the expenditures in healthcare are growing every year. You can see it's currently up to $5 trillion, and it's projected to reach $7.2 trillion, and that's our GDP right now is $20 trillion. So it'll be about a third of GDP within the next 5 years. So healthcare is a major part of the gross domestic product of the United States. And then you may say, well, where does all that money go? A small percentage of it actually goes to physicians. And you see here in orange, physician services, it's about 15% of the total spend of cancer care. Most of it goes either to the hospitals, which is about 31%, and or the other services that are provided. So hospitals get the lion's share, physicians about 15% of that GDP. And how much of that spend, that $4 trillion is in cancer? It's about 10% of the total spent. So about $400 billion a year are spent on cancer care in the United States. But healthcare costs are rising, and I think all of you have probably seen these types of comments, but the reason healthcare costs are going up so dramatically is because our population is aging, and I'll show you a pretty interesting slide that shows that. Unfortunately, unhealthy lifestyles are pervasive in our nation compared to other nations, as I'll point out. We are a hub of innovation, and these new innovations lead to much more expensive procedures and drugs and devices. And because of all these different payment schemes that we have a large administrative burden. About 25% of healthcare costs really are in this administrative burden of filling out the paperwork, going through prior auth, and all the machinations of getting a bill out and paid. And then finally, all these healthcare systems, including my own, are consolidating. They're buying smaller hospitals. They're forming these big mega corporations. And in principle, that's to decrease prices and provide a more value-based product. But when you look at it in earnest, it actually drives up costs because you form less competition in an area and then prices go up. I don't say that to my CEO, but that's a fact. So, so this is an interesting slide here, because if you look in the 1900s, less than 5% of the population was 65 or over. But as you move forward, what you can see is at our current state, almost 20% of the population is now over 65 years old, and the fastest growing part of our population is actually over 85 years old. So unfortunately, or fortunately, cancer is really a disease primarily of the aged. So, you know, the rates of cancer continue to go up as our population ages. The other thing that happens as we get older, we get a lot more prescription drugs. So if you look, you know, between ages, you know, from birth to about 45 years of age, we average about 4 prescriptions per year. But when you get above 65, the average person gets almost 21 prescriptions a year. And some of those are very, very expensive prescriptions, as you would imagine, to deal with chronic diseases. So this is another reason why our healthcare costs continue to climb. And this one is really shocking to me. So when you look at the United States, 60% of people in the United States have a chronic disease. And 40% have 2 or more chronic diseases. And this is what really leads to oversized healthcare costs in the United States compared to other places around the world, as I'll show you. But these really lead to a lot of death, disability, and morbidity that drives up the cost of healthcare. You know, when you look at chronic disease in the lens of obesity, this is sort of a graph of, you know, the average rate of obesity in other nations, 25% being the average amongst developed nations. The United States, 43% of people in the United States are obese. When you compare that to 4.6% in Japan, 7.4% in Korea, even 13% in Norway and the Netherlands, you know, this adds significant burden. Think about all the knees and joints that go out because we weigh too much, and all the orthopedic surgery that has to be done, and so on and so forth, diabetes and Ozempic and all the other things that go along with chronic overweight and obesity. And there's also an increased risk of cancer in patients with obesity as well. So it's a major contributor to costs. And unfortunately, medical inflation is higher than personal consumption inflation, except for the last few years where, you know, the inflation rate went up to 9%. Often medical care is a higher inflation rate than the actual rate of inflation for consumers. So that paints a picture that's very challenging. If you look at the cancer increase, it goes up, it's expected to go up about 34% over a decade in cost. So cancer is sort of keeping up with this, and it's contributing significantly to our spend. So why is cancer expense so high? It's primarily due to drugs. So you know, as you can see, 56% of the care of cancer patients is really due to drug costs, and it's expected to rise by nearly 100% over the next 5 years. In addition to drug costs, devices, now you say, what's a device? Primarily, these are, think about all the imaging equipment that is developed, all the fancy radiation oncology equipment that can cost anywhere from $2 to $5 million per machine. These are the types of devices that we're talking about, and that's expected to grow 105% over the course of the next decade. So the costs are going up both in drugs and devices. And this just shows 1 year's worth of biologic agents that have been approved for cancer. There's 87 drugs that were approved in 1 year. And many of these drugs, as we were talking with our friends earlier, can be as much as $10,000 to $100,000 a month for a patient or the insurance company to pay to be on these life-saving drugs. So it's, you know, it paints a very challenging picture moving forward to control healthcare costs. And this just shows the number of drugs that have been approved really just in the last 20 years. So a dramatic increase in these drugs moving forward. When you look at where we spend this money, which diseases, which cancers, breast cancer really is the largest contributor to the spend for cancer care in the United States. You can see over $40 billion a year are spent on breast cancer. And it's really the big 4 cancers, breast, prostate, lung, and colorectal cancer, where the lion's share of cancer spend occurs. And this is a very busy slide, but it shows the contribution of each of these. And, you know, in breast is the largest, and you can see others as well, but it's across the board increases. Now, the problem is everybody pays for this. It's not just, you know, the insurers, and you can see half of all cancer care is provided in private insurance. About 33% comes from Medicare. Medicaid, about 10%. But unfortunately, you can see that top piece of the pie, nearly $6 billion comes out of patients' pockets. So there is a significant cost, and this is the largest reason for personal bankruptcy is cancer care or health care in old age in an uncovered individual. And it unfortunately also hits the most vulnerable in our society the most. So younger patients, people of color, less educated and lower income individuals are the ones that go through bankruptcy at a much, much higher rate. Fortunately, some laws have been passed which limit the out-of-pocket costs, but still, they're not small for individuals having to pay for this care. And this just shows how much in individual diseases is out-of-pocket costs, and breasts, again, is the largest contributor. So this, I think, this is from the Commonwealth Fund, and what this shows is that the U.S. remains the only high-income country that doesn't guarantee health coverage. And you can see the blue bars there are the countries that provide health care for their population. So without going across, it's primarily all the European nations and Far Eastern nations. But one thing I will point out is all of these countries provide secondary private insurance. So in essence, and this is something that's very important to understand, while they all provide a government healthcare system, there's still a two-tiered system of healthcare. The people who want quicker care, who want it more conveniently, who want it on their schedule, pay for extra insurance so they can get in. And it sets up really an unfair two-tier system in many of these nations. So in the U.S., 38% of patients have government-provided care, and 63% have private insurance. And I think it's that dynamic, and we can talk about that a little bit, that's different, and I think is a very important thing to understand, that while we don't provide care, everybody who needs care is able to get it in the United States in a more timely manner. We're not alone with regards to catastrophic financial difficulties. You can see other nations, Germany, Singapore, China, many patients undergo essentially financial hardship for cancer care. It's not just unique to the United States. So you would think that with all the obesity, with all of the challenges that we have and the costs, that our health outcomes related to cancer would be worse. In fact, again, this Commonwealth Fund report in 2023 makes some pretty stark comments. They say that healthcare spending, and again, this is the first bullet point, both by person and as a share of GDP in the United States is the highest in the world, yet the U.S. is the only country that doesn't have universal health care. Our life expectancy isn't as good, that we have the highest rate of people with chronic conditions, and, in essence saying that our outcomes are not, we're not getting the bang for our buck, if you will, with the outcomes. And they point to obesity. We talked about this as a chronic disease. Also, we're most likely of any other nation to have multiple chronic diseases. And you can see, many other nations are have far fewer multiple chronic conditions. We also have the lowest rate of physicians or per capita and the lowest number of physician visits in the world compared to other places. However, our outcomes are better in cancer, even despite being obese, even despite having chronic conditions, even despite all these challenges. When you look at outcomes in cancer, we actually have, and the way to read this chart is all those to the right have outcomes that are worse than us in cancer-related care and cancer outcomes. Sweden, Canada, Australia, France, the Netherlands, Germany, all these places where universal care is provided have worse outcomes than the United States. The ones to the left, very smaller nations, have better outcomes for a lower cost. Now, one thing, though, that is true is that per life saved, we actually spend more money in the United States than in those countries. So our outcomes are better, but we spend more money to save those lives. Now, there's plenty of reasons for that I'll outline with you, but it is important to note that cancer outcomes are not worse. They're actually better in the United States than most of the world. The other good news is we have some of the highest rates of screening for cancer in the world. The U.S. is in the green bar. So, to the left is breast cancer screening. To the right is colorectal cancer screening. So we actually screen our population much better than other nations. Our hospital stays are the shortest amongst other nations. I joke, the average hospital stay in Korea is 20 days. I mean, could you imagine being admitted to the hospital and that's the average length of stay is 20 days? I would have a stroke if my length of stay was 20 days, but somehow the Koreans, keep folks in the hospital. And the total number of hospital beds is low. You can see, the green bar there. So we have less hospital beds, but our length of stay and our turnover is quite good, which shows the efficiency of our healthcare system compared to others. So just to summarize, cancer is fee for service. Cancer costs are accelerating and are currently about 10% of the total spend on healthcare costs in the United States. The problem is our employers, private insurers, can't keep up with these expenses. So they're starting to really enact some cost-cutting measures. And financial toxicity for our patients is really unacceptable. So what does the future hold? What are we looking at in the near future, or even today? There's some new trends. Unfortunately, cancer is growing in incidence. So as we live longer, more patients are developing cancer. So there's about a 10% growth in cancer rates annually because of the aging population. And most of it is outpatient. You can see we expect the 15% growth in outpatient cancer care and only about a 1% growth in inpatient cancer care. But what's really happening is, as you can see right now, we're on the left of this slide where it's a fee-for-service business, if you will, where you treat a patient and you get paid. But more and more, it's shifting to the right. So to the left of this slide, when it's fee-for-service, the payer has the greatest risk. As you go more to the right, the providers, that's the hospitals and the doctors and the rest, are the ones who have the greatest risk. So to the left, government insurance is the risk. To the right, it's really the physicians and the hospitals that have the risk. Currently, if you look at this, bundling is occurring. So for joints, there's bundling that occurs. You have a knee replacement, you get one fee, the hospital has to make it work. And that is occurring in many instances. It's beginning to go to the right for cancer care. As I'll show you, there is performance-based metrics now, accountable care organizations forming around cancer care. And there are even, as I'll show you, some primary care groups that are owned by insurance companies, I will add, that are in total global capitation. So they'll give a physician's group a certain amount of money, and that's all the money you get to care for your patients for the year. So you have to pick the lowest cost setting so that you have any amount of money left at the end of the year. So that's full risk global capitation to the providers. And luckily, we're nowhere close to that in cancer, but we're moving more and more to that cost-cutting venture. So what's a bundle? Just to put it in perspective, a bundle is essentially, and I'll use, I'm a head and neck surgeon, so if I have a patient come into the hospital on day 1, I do an operation on them, they leave the hospital on day 5. For at least in surgery, it's a 90-day bundle. So for 90 days, we get paid that one fee for all the care that occurs in that 90-day period of time. And unfortunately, about 2/3 of that is outside the hospital. It's, rehabilitation services, it's a skilled nursing facility, so on and so forth. But we're sort of in this performance-based model responsible for that entire spend, even though 2/3 of it's out of our control. So that's a bundle. What is happening, though, is payers are starting to say, look, we can't afford cancer care the way it is. You guys need to make some changes. So what are they doing? They're actually saying to us, and this is, on the left, commercial payers are saying, you can't go to Seidman Cancer Center and get your drug. You have to actually buy it from our pharmacy, bring it into the hospital, and then the hospital can administer it for you. Or worse yet, the hospital's too expensive. You have to go to a private doctor's office to get your chemotherapy. So that's happening now. These specialty pharmacies are owned by insurance companies, as I'll show you. And then they're making it harder and harder to get paid. They're saying, nope, you can't use this drug. You got to use this other drug. And then what's happening on the right is what the government is doing. The government is basically saying, we're not paying you anymore. Your reimbursement rates are going down. Medicare is going bankrupt. We're going to cut your pay. But they're also saying you have to prove that you provide good value, good care, good outcomes for a lower price. And if you do that, you can share in some of the profits. What this shows here is all these insurance companies now are what we call vertically integrated. So on the bottom, whether it's United Healthcare, Aetna, Cigna, Anthem, they all own physicians now. Actually, United Healthcare is the largest employer of physicians in the nation. They own over 70,000 physicians. And what they say is, okay, physician, you ordered a drug. So that drug has to come from a specialty pharmacy. That's the next rung up, which they own. And then it goes to a pharmacy benefit manager who gets a rebate because we can't negotiate directly Medicare with these pharma companies. So the pharmacy benefit managers negotiate a rebate, but then they don't give the rebate to the patient. They keep it. And then that's their profit model all across the system. And all of them have this. They have the providers, they have the pharmacies, they have the pharmacy benefit managers. And as I'll show you, there's a 92% profit margin in these pharmacy benefit managers that insurance companies are taking advantage of. Optum continues, and this is United Healthcare's company, added 70,000 more physicians to their docket. So they are the biggest employer now of physicians nationally. Again, the other thing that's happening is a lot of these companies are saying, well, you got to order through our pharmacy, and then we're going to capitate what you can spend nationally on your pool of patients. So that is happening. And this is continuing to grow. These insurance companies are now owning more physicians, owning more pharmacies, and controlling more of the healthcare spend. The other thing that is happening here is these insurance companies are employing virtual care. So they will give you a blood pressure kit, a thermometer, you check in virtually, and that's a way to decrease costs. And they've also created what are called centers of excellence. So if you have a cancer diagnosis, they'll say, where in your region can you be treated? They look at how much it costs to treat a head and neck cancer at UH versus Cleveland Clinic versus SUMA. And they'll say, well, the lowest cost is at SUMA, so you need to go to SUMA. So they narrow the network to try to decrease costs. That's the centers of excellence there to the right. And, essentially, Dr. Langell and I, both surgeons, what they do is they look at a group of surgeons in a region, and they say the best outcomes are doctors X and Y, so they limit it to just 2 doctors. And they say, we'll send all our business to you, but we're going to pay you 35% less. Take it or leave it. And all the other doctors are cut out of the mix. So that's what some of these centers of excellence have done. The problem is places like my hospital, university hospitals, or other academic medical centers are considered too expensive now, which they are very expensive because there's a lot of infrastructure and research that goes on, but they're being cut out of insurance plans. Patients are not being allowed in many instances to go to NCI designated cancer centers because it's too expensive for the insurance plans to pay for. And, I always love this. United Healthcare is a Fortune 5 company. It's one of the 5 biggest companies in the world. They take in $400 billion in revenues. Their margins are around 8%. And about 82% of it, that's the medical cost ratio, goes to care. The rest sort of is administrative. And you can see, their profits are about 25 billion a year using these mechanisms. And it's really challenging, I think, the healthcare system in general. Now, the government is doing this stuff too. So the government is saying, we need to cut costs. How are we going to cut costs in Medicare and Medicaid? So they're threatening to cut our reimbursement for drugs. They're also decreasing rates directly. They want us to do experiments, if you will, on value-based payments. And I think the bottom one is really starting to negotiate drug prices with pharma, which I think, a little-known secret is the U.S. can't negotiate drug prices. It just started, under the last administration. But other nations can negotiate entirely. So they'll say to Pfizer, if you want access to the Japanese market, we'll only pay you X. And they negotiate down to a very, very thin margin. In the U.S., when Medicare started buying drugs, and it was called the favored nation model, and this was, put into Medicare when Part D was added, we can't negotiate directly with pharma. That's how these pharmacy benefit managers were set up and rebates were given. So in essence, we actually pay a much higher rate for drugs than the rest of the world because that's how these pharma companies can continue to do research and development. And really the U.S. funds all the world's R&D in pharma by not negotiating prices. So if we start to negotiate those prices, the amount of innovation in pharma will really go away. So it's a sticky problem that is really contributing to cancer costs. We did one of these models at UH to try to save money. And what I'll show you quickly is that we actually improved care significantly. We decreased our urgent admissions. We decreased in cancer care the number of ED visits, the number of admissions, the number of people who went to hospice earlier rather than later, that decreased the length in the ICU. But when we looked at our costs over that 5-year period of time, they kept going up. So while we controlled what we could control, it was really drug prices that we couldn't control. It's the red on the bottom, and that just continued to go up the entire time. So we couldn't control the drug price, and it threw this model into disarray. The last thing I'll leave you with is there are disruptors coming into, non-traditional disruptors coming into the cancer market. And these include essentially convenient care settings and as well population managers. So what does that mean? I'll move forward here. Is ChenMed, Oak Street Health, these are big primary care providers. And these are the ones who are fully capitated. So what they'll do is they'll say, you folks have a certain amount of money to care for this population, and they will only essentially send their patients to certain providers to get their cancer care. What's interesting is Oak Street Health was just bought by CVS. Iora Health was just bought by Amazon. Both of these were big primary care practices. One sold for $3 billion. The other one sold for $10.6 billion. It's not the doctors they want, it's really all those patients that those models want. So really what I'll leave you with is academic medicine is in crisis. Academic medical centers are too expensive. Payers are pressuring us to cut costs. And really that's threatening the scholarly ethos of research, education, teaching, because everyone's trying to be as efficient as they can with care. Clinician scientist positions, I think, are diminishing. Only a few centers now can really afford to have people do both clinical and scientific medicine. Research funding is decreasing. And philanthropy is also decreasing just because of potential changes in the tax code. So really, for-profit healthcare systems and private equity is now starting to come into healthcare because of the opportunity that's there. And really, this is sort of self-inflicted damage. So we need to control our costs, be better stewards, provide the optimal care, and really start to educate, our population on better health practices and also on what it means, to sort of be in these value-based systems and the rest. So I'll leave it at that, and I think, we will have some time for question and answers from everybody. I thank you all for your attention.
Hi, I'm Cheryl Powell. I'm the executive editor of the Akron Beacon Journal. And before I became an editor, I served as a medical writer for the Beacon Journal for 15 years. So a topic near and dear to my heart. Thank you, Doctor, for sharing a lot of eye-opening information today. One thing that did strike me, a lot of the numbers you shared, you talked about, the 34% increase in medical costs expected in the past decade, and cancer accounting for 10% of all medical costs, and then talked a lot about kind of the changes that are being inflicted upon providers to try to control those costs, whether it's from the insurance companies, or others. Could you talk a little bit about some things you'd mentioned that UH has done some things? What are some things that doctors and the healthcare system itself can do to try to control some costs without sacrificing patient care and outcomes?
I mean, clearly, the best patient outcomes is everybody's goal. So, keeping that as our North Star, if you will. And what we have to do and what we've begun to do is really try to take out wherever we see redundancies, inefficiencies, so that we can streamline care without sacrificing outcomes. So as an example, drug costs are the biggest factor in care. So if we have the choice between two equally effective drugs, and this happens all the time, more than you would think, and just doing a comparison and saying, drug A and drug B have equivalent outcomes. This one costs $5,000 a month less than this one. Why are we choosing this drug over that drug? And that happens a lot. That's one example. Another example is there's new techniques in radiation oncology. Typically radiation oncology is a 6-week course of radiation, Monday through Friday, 30 courses total. Research has been done that shows that 5 treatments in some diseases done over a week provides the same outcome as 30 treatments over 6 weeks. That's, with significant cost savings. The outcomes are the same, if not even better. So implementing those sorts of things is really important.
And patient benefit too, because they only have to get 5 treatments, right?
Exactly. And I think the other thing that we're doing very aggressively is much more screening. So as an example, lung cancer, even just as recently as 10 years ago, had a 70% one-year mortality. So many individuals who were smokers weren't getting the lung cancer screening that they needed to have. So we sent out proactive reminders, had people do low-dose CT screens, and now our survival rate for lung cancer has gone up by 20%. Because we found more early cancers than later cancers, and they didn't have to have all that intensive treatment with late-stage disease. So those are the types of things that we're doing to try to, streamline care. The best is obviously preventing disease, preventing cancers, but if someone is unfortunate enough to get it, catching it early, having high cure rates, and lower cost of care is really the important thing.
Right. And like you said, also benefits the patient as a whole too.
Absolutely.
So that's the good thing. Talked a lot about money, but let's talk about something probably a little more fun to talk about, research and innovation.
Yes.
In your field, what excites you the most, about cancer research and innovation going on, and particularly in your field of head and neck cancers?
Yes. So, in my field, certainly one of the biggest changes has been the incidence of HPV-related head and neck cancer. So these are cancers that are virally mediated. It's actually a disease, and it's a virus that 80% of us are exposed to at some point in our lifetime. Unfortunately, in a small percentage of people, that virus isn't cleared from our systems and can cause a malignancy 30, 40, 50, 60 years down the road. So those virally mediated cancers have increased in incidence by 300% between 1988 and 2018. It's a sexually transmitted disease. It's human papillomavirus. So educating people about vaccinations to limit, the production of this disease and the persistence of the disease, but then also we and our research group has identified novel compounds that turn off this virus and that can actually be, and this is where AI is important because we found certain mechanisms on how these tumors occur. We had created a molecule that turned off the mechanism, but it costs billions of dollars to create a drug. So we actually used AI, and there's a cholesterol-lowering drug that's on the market that could be repurposed that actually inactivates the virus and lets the tumors, at least in mice, be cured to a very high rate. So now we have a clinical trial with a repurposed drug that costs $10. Wow. It's been around since 1970. It was a cholesterol-lowering drug that hardly anybody uses anymore, but it's shown efficacy in patients. That's one example. Other examples are just the incredible results with what we call immunotherapy. So checkpoint inhibitors. So that in essence, cancers would produce a substance that would put the immune system to sleep. So they protect they create this protective halo around them. Mm-hmm. And in 2017, a drug was discovered at MD Anderson whereby that protective layer is removed around a tumor, and the immune system now is able to identify the tumor. So in 20% of patients who had metastatic disease now are being cured by this drug. So the promise of harnessing our own immune system is incredible. And then the final thing I'll leave you with is we actually can change our immune system now. So there is, and some of you may have heard about this, CAR T therapy, where someone's T cells are literally filtered out of their blood. They're altered so that they identify the cancer's flag, if you will, and then they're grown up in the lab and given back to the patient. And those CAR Ts are putting about 80% of some leukemias and lymphomas into remission. And that technology is really revolutionizing cancer. So it really is the most exciting time in cancer discovery that has ever been.
Definitely evolving very fast and very exciting. Absolutely. For sure. And I have a bunch of questions, but I know the audience probably has questions too. So I'm going to turn it over to the podium and let somebody else ask a question.
Thanks. It was a great talk. I really appreciate you taking the time to come speak with us today. I worked at a very large healthcare system down in North Carolina, and we had some problems with our employees, actually. So the physicians were actually kind of revolting. I think they were fed up with control mechanisms and business practices that they didn't like. And so they started to leave the enterprise and form their own independent practices. I have a friend actually that's a physician at university. Mm-hmm. And he said that he's up to almost 2,500 patients in his practice. And you wonder where things are going to start to crack. They just reached a saturation point and they just can't proceed. So I'd like you to hold forth and talk a little bit about this trend of these doctors leaving healthcare enterprises and forming their own independent practices.
Yeah, that's a great question. I think the previous Surgeon General really brought this to the fore. I think the rate of burnout in healthcare is the highest it's ever been. I think those things that you described are very common. We have seemingly more patients than anybody can take care of that are coming to the doctor more frequently. And there are, and I'll be very honest, incredible financial pressures that are being placed on healthcare systems, and that trickles down to the physicians themselves. So there's no question that physicians are working harder than they have ever worked before. And the challenges that they face are greater than they have. So I think physician burnout is a major issue that all of us are trying to cope with. Some of the solutions have been really employing other caregivers. So you've seen the rise of nurse practitioners and physician's assistants working side by side with doctors to try to decrease the patient burden. But I do believe, and this has occurred in many institutions now, and this has happened in Europe for many, many years. They're beginning to unionize. Some physicians are starting to form unions, and so that they can collectively bargain with the organizations themselves. So it's there's no question that the pressures and the expectations of physicians have really caused. So I think wellness programs, ways to address really what is get back to the joy of healthcare and just what an incredible privilege it is to be a physician is what we try to instill in our physicians to try to combat that. But that's a great question. It's definitely a challenging trend.
I had a quick follow-up to that. I know there's another question too, but with all that pressure and that, what advice would you give to medical students who maybe want to follow in your footsteps? They want to balance, you care for patients and you're also an administrator and do research. How do you balance all that and have a life too?
That's right. I do have 6 children.
Right.
So, you know, it is a challenge. There's no question but it's always been a challenge. And what I always think about is whenever somebody comes to me with the challenges that this gentleman talked about, is I always say, and the med students need to remember this, remember that first day that you walked into a hospital, how you felt. You were so excited to be there and take care of patients, and it was such a privilege to put on that white coat. And really, people let you into their lives in such an intimate way as patients to their physicians. I mean, it's the greatest privilege, I think, that exists in any profession. Get back to that. Think about that as your guiding light, and all the other stuff you can take care of, I think. But too often in medicine, we get cynical and we lose just what an incredible privilege it is to be a physician.
Right, and the lives that you touch, it's hard to
It is. It's
to have
amazing.
that kind of impact
I
in
mean,
any other role.
Some of my best friends are, were previous patients,
Right.
and they, they continue to be dear friends.
I believe there is another question from the audience at the podium.
Hi, thank you. Firstly, thank you so much for including so many great visuals and data in your presentation. It really helped in understanding what you were talking about. My question is related to, I guess, the proverbial cure for cancer that I think all of us growing up, everyone talks about someday we're going to cure cancer, whether that exists or not or whatever. My question is that in various mediums, some more scholarly than others, in recent years, I've heard things like, we already have a cure for cancer, but the patents are tucked away in these big pharmaceutical companies. But there are a lot of ways that we could be doing a lot more, but because of private interest, we're barred from accessing those technologies or that research. Could you elucidate that a little bit and tell me either that's just a myth or that is true and we just need to do better? I'd love to hear your perspective on that.
Sure. That's a great question. I've had more than one patient come to me and say, I want you to give me the drug that Lance Armstrong had, even though he had testicular cancer and I treat head and neck cancer. So there is a thought that, the cure is out there and we're just not accessing it. I think the fact is we're actually curing many, many more cancers than we used to. If you look at the cancer survival rate between, the National Cancer Act went into place in 1971 to today, 30% higher survival rates over that period of time. So we are making a dent. It used to be childhood leukemias were universally fatal. Now they're universally curable. So, a lot of progress has been made. So some diseases we're making incredible progress and curing those patients. Some are very difficult. Pancreatic cancer is the one that many of us have probably had experience with. Cure rates are 5 to 10% for that disease, no matter what we do. So the fact of the matter is great progress is being made through research. It is, there's incredible competition in pharma to find these cures, and they cost a lot of money. I would argue that, there isn't a proverbial cure that we can't access because of pharma companies keeping it from us. Because believe me, there is a blockbuster amount of money to be made if they find the cure. They wouldn't hold it from us if they had the cure. So I think really I leave you with we're curing more people than ever. There's intense research that's going on that is going to save more and more lives over time, especially in this immunotherapy space. And pharma, if they had the cure, would give it to us in an instant.
One last question. We talked a lot about obviously the pharmaceutical breakthroughs that there have been to treat cancer. So I wanted to talk about the role of the clinical pharmacists, in a cancer center like yours. What is their critical role as far as, patient outcomes and also safety?
Yeah, I think pharmacists are incredible and key members of the team. So, whenever a compound is ordered, it's in conjunction with our pharmacists. They help us with dosaging. They help us with, safety. They compound the drug for us. They're really the final check before a drug gets to a patient with regards to the appropriate dosing, appropriate administration. So it goes from the pharmacy to the nurse. The nurses do triple checks to make sure it's safe. But the pharmacists are really just an integral part of the team. For our transplant, bone marrow transplant, they actually round with the patients and with the physicians on service, adjust dosage, recommend one drug over another. And they do help contain costs too. They'll say, you want drug A, but we have drug B that's equivalent. Have you thought about, using this one? And that type of conversation happens routinely.
It definitely takes a team.
Absolutely.
For sure.
Dr. Teknos, thank you for an amazing talk. This is a question that there's no right answer to. You and I have watched outcomes in cancer improve dramatically since our days when we went to medical school, when things like metastatic melanoma was a death sentence. And now 5-year survival rates are actually pretty good.
Yeah.
But you hit also on the value proposition, the cost benefit ratio. Those types of progresses that we've observed have been at a great financial expense, and we know we need to invest in it. At the same time, we have a healthcare system that is struggling financially to have a sustainable solution into our future. How do we balance that when we have patients, for instance, nationally with presentation of metastatic pancreatic cancer that you mentioned, and we know giving them the chemotherapy that's also going to have significant morbidity on them maybe extends life by 6, 7, 8 weeks based on some of the data we have at a cost of $100,000 or $200,000 or $300,000. It's a really difficult position to be in. How do we create something that allows us to look at a value proposition and allow patients to understand quality of life in the remaining years versus the extension of life maybe at the expense of quality?
Yeah, that's a great question. And that's really the crux, I think, of the matter. There are other nations that have organized, centralized healthcare, government-provided healthcare, do calculations. So they actually do what's called an ICER calculation, which is comparative effectiveness, and they look at quality-adjusted life years. And they actually set a dollar amount to say that, and I think it's in the UK, it's about $75,000 per quality-adjusted life year. So when they're making a decision on a drug, they'll say, how much does it cost? And what type of quality and length of life does it provide? And they hit these thresholds. And if it's below the threshold, they say, we're not using that drug. And if it's above the threshold, they'll use it. Now, that's something that I think Americans aren't willing to accept. If my mother could live an extra 6 months, by getting a drug, I would give it to her. And I think the U.S. isn't ready, at least in my opinion, to make that kind of tough decision. But I think, that's what you're, I think, getting at. I think the other thing is, the cost of these drugs in the U.S., and I alluded to this, is much, much higher than other nations because we subsidize research and discovery around the world. I think, if other nations, and I don't want this to be political, but if other nations paid a little bit more for drugs and we paid a little bit less, I think we could deliver healthcare cheaper for our nation and, and a little bit higher for other nations. I think because they do these quality adjusted life years and say you have to be below 75,000, they get the drug for that price. I think, it's incumbent upon us to say to other nations, why don't you let us drop our drug prices a little bit and you guys pay a little bit more. And I think that would help a lot.
Dr. Teknos, thank you very much for an amazing talk for
Thank you.
Vitals today.
Thank you.
Thank you so much for your
Thank you
for
very
your
much.
moderation. Ladies and gentlemen, until next time, please stay engaged because you make the difference in transforming healthcare. You have the power to do so. Please join us next month when we'll hear from Dr. William Hicks, a vascular neurologist and the Vice President for Neurology at Ohio Health. Thank you.
This is VITALS, Visionary Health Leadership in Action.